Sam Morshed from UCSF Orthopedic Trauma. And we're going to be discussing with him the paper that was published in June of 2020 entitled Open Reduction is Associated with Greater Hazard of Early Reoperation After Internal Fixation of Displaced Femoral Neck Fractures in Adults 18 to 65 years old. Hi, Dr. Morshed.
Hello.
I was hoping you could start perhaps by just giving us a brief outline of the article and telling us why you think it was relevant to do this study at this point in time.
Yeah, I think even going back to before the study was initiated, I was trained with a strong bias towards performing an open reduction for femoral neck fractures in young patients, and I came out of fellowship about 12 years ago, really feeling like I had the tools to answer this problem, and treated basically every femoral neck fracture that I encountered in the first 5 or 6 years of my practice with the techniques that I had learned, and realized that my own results, when I looked at them honestly, weren't a whole lot better. I wasn't avoiding problems like non-unions and avascular necrosis by doing the surgery that I thought was the best thing for my patients. And I got together at an OTA meeting with the Orthopedic Trauma Research Consortium, and a bunch of other investigators thought that this was a reasonable question to ask, that we really didn't have a good comparative study. There's a lot of dogma that I think drives the use of open reduction without a lot of strong literature to support it. So we decided to perform, because these are rare problems, even at the busiest trauma centers around the country, and the busiest surgeons really don't perform that many of these operations in any given year. We thought this was a great opportunity to pool resources and experience, and so we decided to get a number of centers together to perform a retrospective review of their femoral neck fractures treated operatively. And we were primarily interested in the question of whether an open reduction resulted in a decrease in complications and late convergent surgeries to arthroplasty. So we decided that we would all look back over about a decade of experience and pull cases for which we had reasonable follow-up, and analyze these using I don't think an overly sophisticated technique, and we can talk a little bit more about propensity analysis and what that means, but it's a technique for adjusting for known and measured potentially confounding variables in trying to get at what might be causal effects of the decision to open for a reduction or not.
Thanks. And I think that that's a good segue into maybe touching on some of the criticisms that would probably follow this study. So the most obvious one being, people would say, oh, well, open reduction is going to select for the worst fractures. And you guys have tried to address that a little bit. Do you mind touching on?
Yeah, sure. So we looked at, measured, and adjusted for the level of the fracture, basicervical versus transcervical. We looked at the Powell's angle, adjusted for that. Looked at the presence of other factors that have been associated with poor outcomes, such as poor posterior comminution, AO classification. I mean, every way in which investigators have tried to classify these injuries that would convey some information about injury severity was adjusted for.
And the result was that you found that essentially did not have an influence on outcomes.
Yeah. So, well, we found that after adjusting for these factors, that the crude difference, which was not that dramatic, actually became quite substantial in favor of a closed approach. So that, ultimately in our adjusted hazard model, there was almost a 2.5-fold increase in the rate of complication leading to reoperation for those who underwent an open reduction versus a closed approach.
Were you surprised by it?
Yeah, when your hypothesis going into a study, or your potential bias, and my bias, has always been towards performing an open reduction, when that's refuted by the data in hand, I think it's incredibly surprising. I think it makes it more credible, honestly. If I were affirming, and we often do, so much of our literature is written almost explicitly to confirm our own practices and biases. This is a case in which the opposite occurred. And I mean, you have to understand that when I saw this, I scrutinized it more than all of the comments that have been written to the JOT about this article. I mean, a lot of them are reiterating my own questions about it. And so we really went back again and again and really made sure that the analysis was done properly, that the modeling was done properly, that we were using a propensity score that really fit the data correctly, and the results stayed as they were. And that was I guess if I was a reader and I know who I am, that would make the results more convincing, because I'm actually reporting something that's completely opposite to what I've taught. The way I was trained and the way I've taught residents and fellows for many years.
So have you changed your practice accordingly?
Yeah, so it's a good question. So I will give a good attempt at a closed reduction now when I'm treating these patients. If I'm not satisfied with that, I still perform open reductions frequently, because I can't, I'm unable to get a reduction that to me is satisfactory. But I didn't contribute a single patient to this study in the closed reduction category. Mine were all open reductions. And I definitely do attempt, and will occasionally achieve a satisfactory reduction with closed means. And those are cases that I would have still opened in the old days. I was taught, even if it looks perfect on imaging, that you open that up and you're going to still see a millimeter of displacement, or or more, and you can't accept that. But I think what it also it also got me to reading a lot of the newer literature that's out there, as well as some of the older literature about the important blood supply that to the femoral neck and head. I think an anterior approach is not without putting some risk to vessels that perfuse at least the anterior neck. And I think that I think that even a very carefully performed open approach, whether you do it via Watson-Jones or a Hoyter or Smith-Peterson, it puts the blood supply to the femoral neck and head at some risk. So I do undertake open reduction with greater care, and I use it more sparingly. That's the extent to which these data have kind of changed my own practice.
Do you want to just touch a little bit on assessing the reduction for this study, first of all, and then what your practice is for assessing a reduction and determining whether or not that's something that you're going to need to open?
Yeah, so it's a good question. We, being that this was a retrospective study, we didn't have post-operative CTs, which would probably be a gold standard, I think, for assessing the quality of reduction. In the paper, we pulled radiographs and had a group of 3 of the senior authors on the study assess them for adequacy of reduction in the the frontal and lateral planes, and found that, interestingly enough, whether you opened or closed, you performed a closed reduction, the quality of reduction is judged by the three of us, was about the same. It was about 70% satisfactory or anatomic, so far as we could tell from postoperative radiographs. That was another surprising finding to me, honestly. But I mean, this is representative. This is what you get from multi-center research, is something that I think is pretty generalizable. It's maybe we should all be shooting for better when we're performing an open reduction. Maybe this is just the best that the best of us can get. I'll leave it to the readers to judge that for themselves.
You finished off the article suggesting that perhaps RCT is required to really answer this question. But after this, I would ask, do you think that you have clinical equipoise? Do you think that in a femoral neck fracture that can be reduced closed, is it reasonable to randomize that person into an RCT for open?
Yeah, I mean, maybe I'll start, by just kind of asking you to pull up figure number one. What we did here was based on our propensity model. The gray bars are basically the percentage of fractures that were contributed from any center that the model would have estimated would be treated with an open reduction. And you can see that all those gray bars they kind of hover around the same range of somewhere between 30 and 65%, maybe just around that. And then you look at the black bars, which is what was actually happening. And you can see that there was one center that didn't perform a single open reduction, far to the left, and there's a center at the far right of the graph that performed an open reduction in every single case. And so clearly that shows that there's a range of equipoise here about, because, ostensibly, the same kinds of injuries are showing up at most centers, and that's what the gray bars would suggest. But what they're getting really depends a lot on the culture of the institution at which they're treated, right? And a lot of centers kind of treated out, they kind of divvied up treatment based on, more or less what the propensity score picked, but they're definitely outliers as well. I think that if this were a more common injury, or we could get a large enough group of centers to contribute cases, I think it is a question that I think is randomizable, and I think would benefit from the causal inferences that you would gain from a randomized trial. But I'm also aware of the enormously controversial nature of this question, and I think that to some extent is an impediment to getting a good randomized trial performed on this question.
Anything else you want to add?
Yeah, I think we had a follow-up paper on this. A lot of comments were sent our way about whether there was a difference that we noticed in the quality of reductions obtained through a more direct anterior Smith-Peter-Hoiter approach versus a Watson-Jones, and did not see a difference. That was a follow-up paper that we published this last year in the JOT. So if that's a question that you have, my response to you would be pick the approach that you are more comfortable with. They both seem to afford the surgeon an adequate exposure to achieve a good reduction. Another interesting point. A lot of people ask the question, why didn't we adjust for the type of fixation? There's a great interest in, and I alluded to this earlier in our discussion, Jeff, about about the different type of implants. Like, did that make a difference? Was that a confounder that you adjusted for? And I think it's really important for us to understand when we're doing these journal clubs and trying to understand the methods behind a paper like this, that you understand that the choice of implant is actually not, it's not a confounder. It cannot be a confounder. It lies on the causal pathway between the surgical approach we use and the outcome we're trying to measure. And if you adjust for a factor that lies somewhere between choice of surgical approach and outcome, you begin to adjust away some of the causal effects that you're interested in studying. We adjust for factors that lie upstream or can affect the choice of surgical treatment. But if you adjust for something that lies on the causal pathway between the intervention and the outcome, you're imposing a new bias on your estimate of outcome. So if that's a question that you have, why didn't you look at, the type of fixation as a confounder? That's my response to you, is that you cannot, if you're trying to understand the effect of surgical approach and outcome, if you adjust for any kind of technical downstream intervention that happens, you're interfering with that causal pathway. And that's why that would require a different type of study, right? What that would require a phase 1 type of study that looks at, the type of, randomizes the surgical implant, and isolates that as a factor of interest in study.
Thanks very much, Dr. Morshed, for joining us today. That was a great discussion.
Thanks for having me. I hope you enjoy the article and have some lively debate.